Good afternoon, everybody. It is my pleasure to be here today with you. You know, the ECG is a very broad subject, so I wanted to simplify as much as possible today, and I highlighted only on practical points in the ECG interpretation. I hope you enjoy the session. ECG is a simple and very informative tools for diagnosing of frequent diseases. So let me start with the session. The conduction system of the heart is usually the signal started from the SA node, which is the heart's natural pacemaker at a rate of 60 to 100 beats per minute. The second station in the conduction system is the IV node. It also receives the impulse from the SA node, and it then conducted to the His bundle and bundle branches. The rate of the IV node is about 40 to 60 beats per minute. And then we have a bundle of His, which is a short segment in the conduction system at a rate of 40 to 60 beats per minute. After that, we have His Purkinje system. Signals at the rate of 20 to 40 beats per minute. And the ECG signals start from the P wave, which reflects the atrial depolarization, and then when the signal reaches the IV node, there is slight delay. It reflects the PR interval, and then when it reaches the His bundle, and when the signal reaches the His Purkinje system, reflects the ventricular depolarization. And after that, when the ventricle is repolarized, it produces the ST segment, and finally the T wave, which reflects the final phase of repolarization. So this is a normal ECG, and of course we have certain intervals and timing of the ECG, which is important to know, because if there is any pathology will interfere with these intervals. We have PR interval, and we had QRS interval and ST segment interval or QT interval. These are the normal ranges of the intervals. And regarding the paper speed of the ECG, the small square is 40 milliseconds and the large square is 200 milliseconds. And this is the paper speed. The speed of the ECG is around 25 millimeter per second. This is a calibration you have to know, and the voltage is about 1 millivolt or 10 millimeter or 2 large square. It is important to know the calibration of the ECG. This is a normal ECG. You can see here the speed is 25 millimeter and about 10 millimeter voltage. Why it is important? Look to this ECG. This ECG sent to me by one of the colleagues, and he thought that the patient has bradycardia. Just look to the calibration is doubled. It is 50 millimeter per second. So if you correct the calibration to standard 25 millimeter, you can see that the patient has normal heart rate and there is no bradycardia. So almost check the calibration of the ECG before you interpret. This is a normal ECG. In my opinion, the ECG should be interpreted in such a manner. I divide it into 3 steps. The step 1 is to assess the rhythm of the ECG. The rhythm, you have to look for the P wave. If it is positive in the inferior and lateral leads, it means there is sinus rhythm. If it is negative, it means it is not coming from the sinus, something what we call the arrhythmia. The second step is to assess the QRS axis and morphology. And the third step is to assess the ST segment, T wave, and QT interval. So if you apply these steps for every ECG, I think you can interpret properly. And today I will focus on the third step, which is arrhythmia, rhythm disturbance. How do we measure the heart rate? The heart rate depends whether the rate is normal, regular or irregular. If the rate is regular, we can divide 300 by the number of the large boxes between the RR interval. For example, in this ECG, we have 4 large boxes. The rate is 300 divided by 4 is equal to 75 beat per minute. However, if the heart rate is irregular, like in AFib or ectopic beat, for example, you have to measure, you have to count the R waves in 6 seconds, multiply by 10. Usually, as in this strip, we have 9 R waves in 6 seconds and multiply by 10 is equal to 90 beat per minute. Where does the sinus node get its energy? The sinus node, or let me say the cardiac cells, usually have automaticity, automatically contracted. But it's, of course, it's influenced by sympathetic or parasympathetic system. So the rhythm disorder, generally for mechanism of rhythm disorder, for any arrhythmia, whether it is bradycardia or tachycardia, we have 2 mechanisms, either the problem in the impulse formation or maybe the defect in the impulse conduction. First step, assess the rhythm. Let me start with bradyarrhythmia, which is a very common subject. The first thing in the bradyarrhythmia is sinus arrest. The sinus arrest, usually the cause is the failure of the sinus node discharge. You can see here this is normal sinus beat, and suddenly it is prolonged. There is a pause here, and this pause is important. The longer the pause, the patient may become more symptomatic. This strip is taken from a patient with 65-year-old. This is a Holter monitor. You can see here the patient has tachycardia, and suddenly the tachycardia terminates, but there is a very long pause, which is about 5 seconds. So this is indicate that the patient has sinus node dysfunction because there is long sinus recovery time. And of course, regarding the indication for pacemaker in such a patient, if the patient has symptomatic, the pauses more than 3 seconds is important. However, in asymptomatic patient, the pauses more than 5 or 6 seconds is important. So this patient is symptomatic and he has very long pause, more than 3 seconds. So the patient has an indication for pacemaker. The second is the sinus bradycardia. The sinus bradycardia, only the sinus node depolarize very slowly. And of course, the sinus bradycardia is a benign condition. Sometimes, frequently, you may see sinus bradycardia in normal, healthy person, especially in athletic or sometimes during sleep. The indication for pacemaker only if the patient has symptoms of syncope or dizziness. Otherwise, doesn't need anything, just follow up. The third problem is tachybrady syndrome. As I showed you in this example, this patient, tachybrady is also one of the criteria of the sinus node disease, the sinus node problem. There is a period of bradycardia followed by tachycardia, sometimes slow AFib. Also this patient. So in summary, the sinus node disease could be sinus bradycardia, could be sinoarterial exit block, could be sinus arrest, or could be tachybrady syndrome, or sometimes slow AFib. You have a patient with atrial fibrillation with very slow heart rate. The second problem is the impulse conduction disorder. The first is first-degree heart block. In first-degree heart block, we have only prolongation of the PR interval. And it is also a benign condition, and frequently you may see in normal person. We have this patient with 60-year-old with a history of smoking and has developed retrosternal chest pain. You can appreciate in this ECG that the patient has ST elevation myocardial infarction, especially in the inferior leads. At the same time, the patient has long PR, the first degree heart block, which is very commonly seen in inferior myocardial infarction. 20% of patients with inferior myocardial infarction usually have conduction disturbance. Why? Because the right coronary artery supply the IV node 80% of the population and supply the sinus node in 60%. And we have second degree IV block. Second degree IV block is could be Mobitus type 1 IV block. Mobitus type 1 only there is progressive prolongation of the PR interval. You can see here the PR is 120, become 20, 280, and progressively prolonged until there is pauses or no conduction. Again, it is a benign condition. Sometimes in a healthy person it can occur without any problem. Such as in this example, if you can see here, the patient has pauses. And this strip was taken from the Holter monitor in patient 30 years old. You can see here there is progressive prolongation. I magnified the entrusted area. So this is 0.20, become 0.28, 0.32, and there is pauses. And if you look to the time of the strip, it's 12:50. Most of the time, the patient may be sleeping at this time, so it is not pathological. It can occur during sleep. The only indication for pacemaker, only if the patient has symptom. Otherwise, it is a very benign and doesn't need anything. Usually it is due to the level of the block in the Mobitus type 1 is in the IV node, and it's due to progressively fatigue until they fail to conduct the impulse. It is not structural disease, it's only functional. However, we have Mobitus type 2. In Mobitus type 2 IV block, there is no progressive prolongation. We have suddenly drop beat like this. And usually the level of the block is below the IV node, in the His bundle or in the bundle branches. So it is, most of the time, is pathological. It's due to structural damage of the IV node. And it's one of the common indication for pacemaker. We have a pattern what we called regular 2-to-1 or 3-to-1 IV block. This ECG was taken from a 65-year-old with dizziness and fatigue. Usually, we can appreciate there is 2 P wave with 1 QRS, and the patient has bradycardia. This pattern could be, it's also a second-degree IV block, but could be Mobitus type 1 or could be Mobitus type 2. We have certain maneuvers to differentiate between them. I not discuss today because our session today is only ECG, so we will discuss in the future sessions. This is high-grade IV block. Again, it is a second-degree IV block, but there is 3 P wave for 1 QRS. In high-grade IV block, there is still a relationship between P and QRS. But in complete heart block, there is complete dissociation. There is no relation between P and QRS. We have third-degree IV block. In third-degree IV block, there is complete dissociation between P and QRS. As in this example, this patient also has inferior myocardial infarction complicated by complete heart block. Again, this ECG. If you look to the P waves, you can see the distance between P and QRS is different. So this is IV dissociation. There is no relation between P and QRS. This is complete heart block. the previous ECG, there was some relation between P. Of course, all of them is an indication for pacemaker after exclusion of the secondary cause, because sometimes we have a secondary cause for IV block. And we have bifascicular block. Bifascicular, it means there is right bundle branch or left anterior fascicle, both of them blocked, or right bundle branch, left posterior fascicle, or left bundle branch, which is composed of anterior and posterior fascicle, both of them are blocked. This is bifascicular block. Left bundle branch block, which is very common. In left bundle branch block, the direction of electricity is changed. Usually, we have block in the left side, so the signal should come to the right side first and then go to the left. That's why the QRS is prolonged, because the duration is increased, the QRS is prolonged. And then there is deep S in V1 and positive R in viscous. Why? Because the direction of electricity goes from right side to left. That's why any leads in the right side, like V1, become negative, and any leads in the left side, like V6, V5, lead 1, IVL, become positive, because the direction of electricity is toward that leads. That is the left bundle branch block. The QRS should be more than 120, and there is broad prominent R wave in V6, V5, sorry, and there is prominent S in V1. This ECG is left bundle branch, and of course we have several causes for left bundle branch. The most common cause is ischemic heart disease or cardiomyopathy, or maybe hypertension or aortic stenosis, and sometimes anterior myocardial infarction, or sometimes degenerative. In right bundle branch, exactly is opposite. The right bundle is blocked, so that the signal goes to the left side and then comes to the right. That's why the QRS is prolonged. And because the direction of electricity is from left to right, so the V1 become positive, and there is deep S in V5, V6. Right bundle branch sometimes could be normal variant. It's not necessary to be diseased all the time. But there are also several causes for the right bundle. For example, in this patient, as myocardial infarction before few weeks, and there is still right bundle branch block. So the right bundle could be in the right ventricular hypertrophy or cor pulmonale, or maybe due to pulmonary embolism, ischemic heart disease, or in congenital heart disease like ASD, or cardiomyopathy, and sometimes also degenerative. We have secondary cause like iatrogenic, could be drug-induced. We have certain drugs that cause bradycardia, or sometimes post-operative, like ASD repair or VSD repair or aortic valve repair, complicated by heart block. Sometimes post-cardiac ablation also it may occur. Or sometimes coronary artery disease, high vagal tone in athletes, and hypothyroidism, or could be severe hyperkalemia. We have 4-year-old child after VSD closure. This bradycardia, there is P wave, but there is no relation between P and QRS. There is IV dissociation, so it is complete heart block or post-VSD closure. This patient has end-stage renal disease and presented with this ECG and suddenly collapsed. The patient has bradycardia, of course, and there is no P wave at all. But the QRS and T collide with each other. So this is a sine wave of hyperkalemia. the patient, the potassium was 8 millimole, and the patient is collapsed after hemodialysis. This is the same ECG of the same patient. So always try to exclude the secondary cause of bradycardia. And this patient, 75 years old, presented with syncope. And patient complained of chest pain few days before. Again, this patient has complete heart block, IV dissociation. When we receive the patient, you can appreciate here also T inversion here in the inferior leads. So the patient has inferior ischemia complicated by complete heart block. And this is the coronary angiography. You can see here subtotal right coronary artery lesion. After fixation of the right coronary, after a few days, the patient's heart rhythm returned back to normal. Still, we are in the rhythm disorder. We finished the bradyarrhythmia, so let me start the tachyarrhythmia. The tachyarrhythmia, again, could be defect in the impulse formation or could be defect in the impulse conduction. Defect in the impulse formation, we have sinus tachycardia. Sinus tachycardia, the defect is in the sinus node, just it fires very fast. Could be due to automaticity. The heart rate is more than 100 to 180 beat per minute. The sinus tachycardia could be appropriate sinus tachycardia, some secondary to fever or drugs, or sometimes anxiety or some sort of infection, sometimes fever, and maybe due to electrolyte disturbance, sometimes pregnancy, or could be inappropriate sinus tachycardia without any cause. The patient's heart rate fires very fast. And we have atrial tachycardia. Atrial tachycardia, the defect is in the atrium, and the heart rate is more than 100. Also, it has several mechanisms. Could be automaticity, could be triggered activity, could be re-entry tachycardia. We have premature contractions, and this premature contraction could be in the atrium. It's the premature contraction in the atrium. How to differentiate? It comes earlier, and the P wave is different from the surrounding P wave, and it's followed by compensatory pause, like this. And usually it is a benign condition, frequently doesn't need anything, or could be junctional premature beat, the same but in the IV node junction, the same criteria, there is no P wave, and could be ventricular premature complex. The defect is in the ventricle. It is common, PVC. I'm sure all of you recognize the PVC. It could be bigeminy every other beat. It could be trigeminy every third beat, or could be quadrigeminy every fourth beat. How you differentiate PVC? Usually the QRS is wide more than 120 millisecond, and there is discordant between QRS and T wave. For example, for those leads with positive R, the T wave is negative, and for those with negative, the T wave is positive. There is some repolarization abnormality in the QRS, and it comes earlier, followed by compensatory pause, and it is very common problem. Usually we have several causes. The most common cause is anxiety, or sometimes excessive caffeine intake, or sometimes in intensive care, maybe due to hypokalemia, hypomagnesemia, or due to myocardial ischemia. And we have defect in the impulse conduction disorder, such as atrial flutter. This is a flutter waves. I will discuss later on how to approach to patient with narrow complex. This is just rapid screening of the tachycardia, or maybe atrial fibrillation. In AFib, there is irregular RR interval, and there is no P wave. And it is also very common. and could be AVRT. In AVRT, when you have extra pathway that connects atrium to the ventricle, bypasses the AV node, and could be orthodromic or could be antidromic. In orthodromic, when the conduction passes through the AV node and comes back by the accessory pathway retrogradely, while in antidromic, the conduction goes through the accessory pathway antigradely and through the AV node retrogradely. And we have AVNRT, which is very common. This is AVNRT, and we have VT. VT also may be monomorphic VT, or could be polymorphic VT, or could be torsadipua VT, which is in the setting of long QT interval. Or could be VF. VF, there is no QRS at all. So what is SVT? SVT usually is a common term or is an umbrella term, involves any arrhythmia above his bundle. It may be AVNRT, it may be AVRT, it may be atrial tachycardia, sinus tachycardia, or atrial fibrillation. All are SVT. So the SVT is a general term. You have to mention in the scientific name of each of them. As I mentioned, all the tachycardias we called SVT. And in general, tachyarrhythmia could be regular, could be irregular, and could be narrow, could be wide. And each one of them has several differential diagnoses. So let me start with narrow complex tachycardia. This algorithm is very important. If you apply for any narrow complex tachycardia, I can say 80% you can recognize any tachycardias. First step, whether the patient has regular or not. If it is irregular, the differential diagnosis could be AFib or atrial tachycardia with flutter with variable AV conduction, or could be multifocal atrial tachycardia. Then the next step, if the patient has a regular tachycardia, look for the P wave. Usually, if there is no P wave, most likely AVNRT. If there is P wave, you have to correlate the P to the QRS, whether every P followed by QRS or the P wave is greater than the QRS. If the P wave is greater than the QRS, it may be atrial flutter or maybe atrial tachycardia. However, if the P wave has followed by one QRS, then the next step you have to measure RP interval. I will discuss what's RV interval in the coming slides. So let me start how to approach to any SVT. This ECG is regular or irregular? This is irregular, clear. Is there any P wave? No, there is no any P wave. If we apply the algorithm, if there is irregular and there is no P wave, so the differential diagnosis could be either AFib or multifocal atrial tachycardia or flutter with variable AV block. As there is no any P wave, so the condition is atrial fibrillation. The criteria for atrial fibrillation, when there is irregular rhythm, there is no P wave, and there is variable ventricular rate. Another patient, 70 years old, with history of palpitation, and she's a known case of COPD. Again, it is regular or irregular? Sorry? Regular? Irregular, yes, you are right. Is there any P wave?
Yes.
Yes, very good. P wave, yes. These are all P wave. But the P wave differ in morphology. This P wave is different from this P wave. So different shape P wave. And the patient has coped. Usually this is a multifocal atrial tachycardia, frequently seen in patients with COPD or chest infection sometimes. It's characterized by irregular rhythm, similar to AFib, but there is P wave. Irregular, but at least 3 distinct P wave morphology. So in this patient, you have to correct the underlying cause of hypoxia like COPD, and at the same time, you have to give a drug that controls the heart rate. This ECG, irregular. And is there any P wave? From the first look, yes, it is difficult to see any P wave. But close observation, you can see there is in V1, there is P wave. 3 to 2 P wave for 1 QRS. This is an atrial tachycardia with variable IV block. What is the difference between this ECG and the previous one I showed you the slide before? This ECG. The difference is just in the P wave. The P wave is different in this ECG. We have 3 morphology of the P wave. However, in this ECG, single morphology P wave. So this is atrial tachycardia, or sometimes maybe atrial flutter with variable IV block. So we finished the irregular tachycardias. I showed you 3 examples, each one for the condition AFib, MAT, and atrial tachycardia with variable IV block. So let me shift to the second part. If there is P wave. If there is no P wave, what could be the cause? This ECG is very clear, narrow complex tachycardia, regular, and I can't see any P wave clearly. So if we go to the algorithm, this is most likely AVNRT, as there is no any P wave here. Because in the AVNRT, the circuit is in the IV node, so the atrium and ventricle simultaneously depolarize. So there is what we call P on R phenomena, the same contraction at the same time. That's why you can't see the P wave clearly. If there is regular tachycardia but there is P wave, the question whether the P wave is exactly similar to the QRS or greater than the QRS. If it is greater than QRS, like in this example, this is narrow complex tachycardia. Anyone can see a P wave here? Yes. These are P wave. 2 P wave with 1 QRS and regular. So the P wave is greater than the QRS. The diagnosis must be a flutter or tachycardia. Because only in atrial flutter or atrial tachycardia, the P wave is greater than the QRS. As there is sawtooth appearance here, that undulating pattern, this is typical atrial flutter. And if we apply to this example, the atrial rate is greater than the ventricular rate, so the diagnosis must be atrial flutter or atrial tachycardia. If there is 1-to-1 relation, P wave and QRS, then at that time you have to calculate RP interval. What is RP? The RP is to calculate this R, the onset of the R to the onset of the P wave. And of course, each one has several differential diagnoses. I will show you in examples. This patient is the same patient, narrow complex tachycardia. From the first look, it is difficult to see any P wave in this ECG. And this is the same patient after conversion to sinus rhythm. Why it is important to bring the ECG at the during sinus rhythm? Because always compare the rate during tachycardia and sinus rhythm is very important. Why? As in this example. You can appreciate here there is some protrusion at the end of the QRS, which is not present during sinus. I magnified for you this one, the magnified area. This protrusion is very clear here. It is not present during sinus. So what does it mean? It means something hidden inside the QRS, which is P wave. Because the heart rate is very fast, the P wave is hidden inside the QRS. And this is typical feature of IVNRT. As I told you that the simultaneous contraction of the atrium and ventricle at the same time. So this will happen in IVNRT. And if you calculate the RP from the onset of the R to the onset of the P is very, very short. So this is only happen in IVNRT, the short RP tachycardia. Okay, what about this patient? It is also regular narrow complex tachycardia. It is 45-year-old patient with congenital heart disease. The patient has ASD, also present with recurrent palpitation. Okay, it is regular or irregular? Regular, yes. Is there any P wave? Yes, there is P wave. I magnified the area. This is P wave. Inverted P wave, yes. Inverted P wave. So the P wave is inverted in the inferior lead. It excludes sinus tachycardia because, as I told you, that the P wave should be positive in the inferior lead. The remaining differential diagnosis, this P wave, if you calculate the R to P wave is very long RP tachycardia. The differential diagnosis, coming back to our algorithm, could be atrial tachycardia, PJRT, or atypical IVNRT. Most commonly atrial tachycardia, as the patient has ASD before. So almost always check the RP interval and look for the P wave. So in summary, in any narrow complex tachycardia, the first step, whether regular or irregular, if it is irregular, we have atrial fibrillation, or we have atrial tachycardia or flutter with variable IV block, or multifocal atrial tachycardia. If it is regular, look for the P wave. If the P wave is not present, it is most likely IVNRT. If the P wave is present, correlate the P wave to the QRS, whether one P wave or two P wave. If the P wave is greater than the QRS, it could be atrial flutter or atrial tachycardia. If you have one P wave for QRS, look for the RP. If the RP is short, it's IVNRT. If it is long, it could be atrial tachycardia, atypical IVNRT, or PJRT, which is accessory pathway, this one. So I finished the narrow complex tachycardia. The VT is the most common cause of wide complex tachycardia. 80% of all wide complex tachycardia are VT. So almost always, whenever you are in doubt, please treat any wide complex tachycardia as VT until proven otherwise. We have certain features to differentiate between SVT with aberrancy or with pre-excitation from VT. First, the IV dissociation. IV dissociation is very, very specific for the VT. This one, you can see the P wave here is transiently appears during the VT runs. This is IV dissociation, and this is very specific. Whenever you have IV dissociation, 100% is VT. And we have capture fusion beat also, if it is present, indicate VT. What is capture beat? This is capture beat. it means there is some normal sinus beat is among the VT runs. And we have capture fusion beat when there is fused between VT and between sinus, this beat. Also, it's specific for VT. And we have concordancy, whether positive concordance or negative concordance. This is negative concordance. All the precordial leads are negative. Again, this is in favor of VT. Or sometimes if you don't have these criteria, look for the morphology of the QRS. Absence of the RS pattern is also goes with VT. RS pattern, it means you have concordance or positive or negative concordance. If you have RS pattern, measure the onset of the R to the S nadir, which is if it is more than 100, the wider the possibility of VT is more. Of course, the axis is important. The shifting axis toward the left side goes with VT. And also you have to have ECG during sinus rhythm. Sometimes the patient may have pre-excitation during sinus rhythm. It will give you diagnosis. Or if the patient has pathological Q wave in the sinus rhythm, you can say this is VT. And history is very important. Every ECG should be interpreted in the context of history taking. Without history, even for more experienced cardiologists, sometimes it will wrongly interpret the ECG. And definite diagnosis, of course, by EP study. Sometimes some ECG may be very difficult, even you cannot 100% sure about VT or SVT. But as I told you that whenever you have in doubt, you have to manage as a VT. Of course, in the VT, we have another algorithm. Again, whether it is regular or irregular. If it is irregular, it could be atrial flutter or fibrillation with bundle branch block or with pre-excitation. If it is regular, you have to look for the IV relationship, whether IV dissociation present or not. If it is not present, look for the morphology of the QRS, because every VT, either right bundle branch morphology or left bundle branch morphology. If the right bundle or left bundle branch morphology is not typical, it goes with VT rather than SVT. I will show you what is the typical right and left bundle branch. This is typical right bundle and left bundle. In typical right bundle, usually the initial R is small, followed by S, and the secondary R is large in V1. In V6, you have deep S. In left bundle branch morphology, when it's typical, usually the first deflection is very short, less than 40 milliseconds, this deflection from R to S. And you have the onset of the R to the nadir S is also short, less than 70 milliseconds. This is typical left bundle branch. Anything more than this goes with VT until proven otherwise. I will explain later on in the following examples. The mechanism of wide complex tachycardia, as I told you that most of the wide complex tachycardia are VT, but maybe SVT with bundle branch block, maybe SVT with pre-excitation, or maybe ventricular paced. Patient has pacemaker and develop tachycardia, looks like VT. Okay, what sort of tachycardia is this? It is VT, or maybe antidromic IVRT. To make it simple, it is regular or not? Regular. So the next step, look for any dissociated P wave, if it is present. We have two differential diagnoses, either VT or pre-excitation tachycardia, or WPW. For any pre-excited tachycardia, usually the accessory pathway is around the mitral or tricuspid valve, short segment. So any problem in the apex goes with VT rather than accessory pathway. So whenever you have QS in the viscous, this is Q, deep Q. QS in the viscous or V5, it means it is VT because the accessory pathway not reaching V5 viscous. And if you have IV dissociation again, it goes with VT. Coming back to our ECG, for the IV dissociation, just usually select the leads with low amplitude. For example, this lead, the amplitude is very small in comparison to the other leads. So you can appreciate the P wave intermittently. This is P. This is not present. Coming again. This is P. So this is IV dissociation, very clear. So whenever you have IV dissociation, you can swear that this is VT without any doubt. So the diagnosis, a final diagnosis is VT, certainly. Okay, what about this ECG? Is VT with left bundle branch, VT, antidromic IVRT, or any of the above? This is regular or not regular. Is there any P wave? I can't see any P wave. I can't see IV dissociation, no capture beat, no fusion beat. So I look the morphology of the QRS. This is left bundle branch block morphology. So I apply the morphology of the left bundle branch to know whether it is typical morphology or not. This algorithm, we don't have IV dissociation, we don't have QS in V5, V6, so the only remaining, I have to look for the morphology. I magnify the interested area. This is morphology. As I told you that the left bundle branch morphology, if it is typical, it should be the initial R to S should be less than 40. This is again very short. And the duration of the R to the nadir S is less than 70. So it goes with SVT, with aberrancy, rather than VT. As we expected, yes, we did radio frequency ablation and it looks to be left lateral accessory pathway. So this is this ECG, although wide complex, but it is SVT with aberrancy rather than VT. Okay, what about this tachycardia? Again, wide complex tachycardia, regular. It is positive, negative concordance, goes with VT. So SVT with bundle branch is already excluded. The remaining diagnosis, also we have to apply the morphology to this. In the morphology, the R to S is very long, more than 40, and also the initial R to the nadir S is more than 70. So it goes with VT. And also there is some notches in the descending part of the S wave, which is also goes with VT. So the diagnosis is VT. What about this ECG? It is regular wide complex tachycardia. I selected the leads with small amplitude to look for the P wave. There is some IV dissociation, and beside the IV dissociation there is also QS pattern in V5 viscous and negative concordance. So it goes with VT easily. Whenever you have negative concordance, QS pattern in V5 viscous, don't hesitate. This is VT. And at the same time, look for the IV dissociation. What about this ECG? It is fusion beat present at the starting of the VT. So it's specific for VT. It is easy. And sometimes even when we apply all the algorithm and features, we cannot reach the diagnosis, as in this ECG. But sometimes simple baseline ECG will solve the problem. In this ECG, usually it is wide complex tachycardia, but all the features we cannot exclude, whether it is VT or SVT with aberrancy or pre-excitation. But simple baseline ECG, as in this one, this is baseline ECG of the same patient. You can see here there's pre-excitation, delta waves. So it solved the problem. This is, that's why this is proven. It is antidromic AVRT, accessory pathway. This patient, yesterday I received this patient from emergency. This is a 65-year-old male patient with previous MI, presented with palpitation for the first time, yesterday admitted in our cardiac unit, okay, with palpitation. Actually, he received a DC shock. I told you history is very important in the ECG interpretation. The patient has previous MI, and the ECG has right bundle branch block morphology, but it is quite atypical. This is a typical right bundle. As I told you, the first deflection small, the second deflection is large, but this patient has monomorphic R, and there is QS in the V5, V6. Also there is AV dissociation. There is some P wave here and not present in other leaders. So this is VT without doubt. And we did echocardiography. There is large apical scar in the LV with LV dysfunction. And usually this patient has an indication for ICD implantation, as the patient has for secondary prevention. The patient has LV dysfunction, ischemic heart disease, and VT. This is, I think, the last ECG. It is 55-year-old patient with congestive heart failure, received high-dose diuretic. The patient has polymorphic VT. It is as if there is twisting around the isoelectric, usually due to electrolyte disturbance, mainly hypokalemia, hypomagnesemia. This is polymorphic VT. Torsa diploa is usually occur in the setting of long QT. Yes, you are right, but this is polymorphic VT. And for today's session, this is the last slide.